The theme for 2023 is Use Heart, No Heart. That understanding and caring for our arts. So, along with Boehringer Ingelheim, we have come up with this brilliant series of discussions on different topics or all around get smart with your heart. So, for this, the topic of discussion of the very first episode is cardiovascular health in India, analyzing the current status and its challenges. Allow me to introduce to our esteemed set of panelists present for this session. We have Dr. Rajendra Borkar, Medical Superintendent of South Goa District Hospital. Sir, welcome to the show. Thank you for joining.
Thank you.
We have Professor Dr. Cardiologist and HOD of Cardiology for Government Medical College, Raipur, Chhattisgarh. Sir, thank you for joining. Welcome to the show. We have CK Das here with us, who's a cardiologist with SECR Railway Hospital. Sir, thank you for joining. Welcome to the show.
Good afternoon.
Yes, with that, let us get started with our discussion. I am Dr. Savri Sawant, Public Health Specialist from Team IHW Council, and we would be talking today all around cardiovascular India. So my first question is to Dr. Borkar. Sir, given your extensive experience in health, please can you highlight the landscape of cardiovascular and how does it vary underserved communities compared to the affluent communities? Are there any variations that you see in your practice or with your work with public health?
Yeah, good afternoon, everybody. Savri, I would like to in Goa, we have about 30% population of Goa in the age group of 25 to 45 who are mentioned. So this is in line with what is happening in India. Approximately 1 in 3 people in the age this suffering from hypertension. What we have found they are, and so the interesting is pushing us towards hypertension. So also diabetes. And the interesting supposed to be a state diabetes also. What we have found now in Goa from the generation, now we have the younger generation who has started suffering from hypertension and cardiovascular diseases. What we have found is that males are little more predisposed to hypertension than the females. But as your question, whether affluent or underserved population, that difference we don't find in Goa. What we are finding is that both the populations are suffering. Such in Goa, there is no called as urban and rural. I mean, either it is urban. So therefore, we don't have much differentiation between the urban and rural. And therefore, the number of people in rural area and the number of people in urban area suffering from diabetes, approximately the number is same. So this picture currently is.
For the numbers, and as we can see, 1 in 4 people are hypertensive and suffer from hypertension. Most of them are unaware. So our next question is to Dr. Smith. Sir, we saw the prevalence and understanding of cardiovascular or hypertensive diseases in Goa. Scenario from Raipur, Chhattisgarh, where you are, and are there any specific factors specific to your area that contribute to cardiovascular health landscape in any form? Sir, you are on mute. Can please unmute.
Like India, regional flavor to what Dr. was portraying for Goa. And the major difference that I feel I had seen in my practice is that Chhattisgarh is a new state. It's a newborn state. It's old. There is a migration from tribal areas to cities. area. And this migration is in a huge damage or a huge problem for those populations migrated. Because previously they have been tribal, they have been living in areas, living very close to nature, unexposed to processed foods, processed sugars, processed salt, and all those things. Now this population has migrated from that tribal area to cities and to affluence. So now they are into jobs, they are into private jobs, they are into government jobs. There is a sure income, there is sure no shortage of food, and that food is now more westernized. So this presents a different problem because this population then catches those risk factors early, which are responsible for cardiovascular diseases in the long term. And that is what I am observing. Those populations which have migrated, they in the span of 3 to 5 years become diabetic, become hypertensive. It may be because of their free will living at nature, and then loads of work and loads of risk factors at cities. Uh, those that exercise, those climbing of hills in tribal areas versus moving about in vehicles in two-wheelers and four-wheelers. So that drastic change in lifestyle has presented us with more patients who are younger, who are more obese, who are early diabetics, who are early hypertensives, and they are presenting with more myocardial infarctions, more heart problems, cardiovascular problems. And on an average, we have analyzed at our institute, we find that almost one-third of the patients are under 35 years of age. And again, here there is slight male preponderance, but the females are shoulder to shoulder in this area also. And I would blame use of tobacco, especially there is one thing called as guraku, which is a mixture of jaggery and tobacco, and it is used like a toothpaste. So that is being used by males and females many times a day, and it is not taken as a taboo like smoking or any other thing. It's taken as a normal way of living for the tribal people or the local people, and that results in early cardiovascular diseases, early myocardial infarctions in females of Chhattisgarh. So this is the major difference I find. Then among dyslipidemias, we find that triglycerides are higher in local population. Then we consider that LDL or total cholesterol. Total cholesterol is also higher. So this is major difference. Otherwise, I agree with Dr. Borkar that hypertension and diabetes, they have a prevalence. Like diabetes would be somewhere around 7 to 8% that we have seen. The other surprising thing that one must highlight is in 90s, the ischemic heart disease stood at 15th position. Today, it holds the first position in loss of daily in Chhattisgarh. So 1990, diarrheal diseases and lower respiratory tract diseases were the topmost killer or topmost loss of daily life. Whereas today, ischemic heart disease has replaced diarrheal diseases and lower respiratory tract infections as the number one killer. And 24% of the death in the state from a local survey is among all the deaths is because of a cardiovascular reason. So these things these are alarming things, and we need to understand why this is happening. If we do not measure it, we do not understand it, probably tomorrow we'll not be able to prevent it.
Thank you, sir, for very rightly pointing out that the prevalence of cardiac diseases have been on the rise in Chhattisgarh state, particularly. All the numbers that you shared of specifically ischemic heart disease being on the number one now, we can very well conclude that if the government is not working very efficiently in generating awareness amongst people regarding the different harmful effects of unhealthy lifestyle, this can lead to and more people developing heart related and associated lifestyle diseases in near future very early on. So we saw the scenario how it is in Goa. Dr. Borkar shared the numbers, which is 1 in 3 people are hypertensive, 1 in 4 people are pre-hypertensive, which is pretty much comparable to our overall India, ratios. When you look at the entire country on a broader level, this is similar scenario. And I believe in Goa, it is exactly replicating the same, as owing to the multicultural population of different sectors due to tourism, etc., that we have mixed sort of population over there. Very specific issues you highlighted in Chhattisgarh due to migrant population, which is specific to the state, which also makes us understand the scenario of pre-partition India, something along the same lines that Chhattisgarh health scenario is facing, that when people started getting free will to grow and eat the calories, carbohydrates, fats, they started their weight started getting increased compared to how the living conditions were in India before. So we can see the comparison over there. We would like to know what is the general health status when it comes to cardiovascular health for people in railways. For railway employees, we have Dr. C.K. Das with us, who is cardiologist, SECR Railway Hospital. Sir, given your expertise in cardiovascular care within the railway healthcare system, can you share some unique challenges or opportunities that you come across, or that you notice evidently in managing cardiovascular health amongst railway employees and their families?
Yeah, good afternoon. Actually, I don't think whether you're getting my video. Whether video
Sir,
is
we are
having some,
getting your video and audio both.
you are getting in some other number, I think. Yeah.
Yes, but
So,
you can go on. You're audible.
yeah, I think that will suffice. Things are a little bit different here. My predecessors like Dr. Smith and Dr. Borkar, they have their specific problems with the specific reasons. Here, things are a little bit different. I have worked for continuously 6 to 7 years with this type of preventive cardiology in Indian Railway sector, particularly in Southeast Central Railway in Bilaspur. That, of course, it occupies maximum part of this railway in Chhattisgarh. So now, railway population comprising of a cosmopolitan habitat. It has Chhattisgarh culture, it has Odisha, it has Madhya Pradesh, it has a little bit other sides of Jharkhand, and we have a mixed culture. Now, what were the unique challenges to me initially when I came here in 2011? We started one pilot project in assessing and then bringing out the solutions to it. The common challenges on both sides, either the public or employees side, and also from the healthcare providers. First, come to public, that is in terms of employees and its family members. We had faced ignorance, unawareness, and superstitions as usual in the entire country. I think you have the same problem. So people are not aware that we have these are the symptoms of cardiovascular system, and these are this is the time to go and report, and what we should not do, like particularly the modern and so-called faulty lifestyle in all generations. I'm not talking about the elderly people, even from the late school age, like 11, 12 classes. So all this we had planned in a different way. We took out a project named as Doorstep Interactive Heart Awareness Drive. So we found if you call somebody that there is a clinic in the hospital known as preventive cardiology, nobody comes to peep inside because they are bothered only about the current problems. So we took out in a challenging way. But this team should include a popular doctor, whether it's a senior physician or a cardiologist even, along with some other doctor and staff. And there should be organization people to help you out there, find out a place, common place like school buildings or some office buildings, which is closed in the evening hours, and call the families, particularly ladies and grown-up children and others, including employees, and have a good interactive session with audiovisual projections about the heart diseases, how it happens, what are in our hands. In fact, we followed the footsteps of Interheart study reports of 2005. It came out with 9 risk factors. Apart from these 5 conventional hypertension, diabetes, dyslipidemia, smoking, and obesity, we have physical inactivity, lot of lack of vegetables and fruits in our diet in regular activity, and mental stress, of course. So we analyzed this and we told them to come out with the problems. We had circulated one register to taking their own problems in that and signature and mobile number. And we find surprisingly 40% around people of this population. We had around 4.5 thousand population study. And they said 40% of these people, we don't have any problem. So we focused on those 40% population, called them separately on 2 days in a week and analyzed, and we found out of that 40%, again, some 15% have diabetes, 11% have hypertension. 11% diabetes, 15%, 20% hypertension, and some ECG abnormalities, etc. So in our society here, 40 to 50% people carry these diseases silently without any symptom. And problem is, our people do not want to come to hospital for even primary check unless they have a symptom. So this we focused on that, all those deliberations, that it's not that if अगर आपको कोई तकलीफ नहीं है, आप बीमार से पीड़ित नहीं, ऐसा मत समझिए. You should go to hospital and check and have a card and get it updated every year. If there is problem, you go to a physician and get it off. So this study we did, and one more interesting finding was 60% people do not go for regular walk or exercise regularly, and 70% do not have a habit of taking regular foods in their diet. This is I'm talking because we really found those factors in inter-health study, in our own study also. Yes, these are the problems. It's still society people. Railway, where people are well paid, they have all financial capacities, not like other states and scenarios. So this population is like this. On the other hand, opportunities. Railway has a very good, wonderful infrastructure. Like this, I think no other state can have this type of infrastructure, communication-wise, and even staffing, manpower, machines, everything we have. So we try to utilize with general administration, and we try to do a lot of this type of activities over telemedicine, like features, or over video conferencing also. And we came out with a good result that within 3 to 4 years, people could understand, people could utilize, people could save time during heart attacks and acute cardiac emergencies. They could understand the depth of it, and they immediately present themselves to the casualties without losing time. They come to the hospitals, and I think this was and this paper was published also in 2019. So this paper was well discussed in different seminars of Indian Railways platforms. So I think we are sharing the same problems as other doctors say, but along with that, there's some privileges are also available in railway, and the administration should continue to have this type of activities through the medical department. And I think things are not very far that we can achieve a good result of preventive cardiology in this particular region.
Very well shared, sir. That is some brilliant study and brilliant work that you did. And I believe Railway Health Services are to, given credit for that allowed, researchers to conduct this sort of study, not amongst just the employees of Railway, but also within their families. If you can please highlight what was the, size of the study population that this study was conducted on, and if there was any specific age, bracket of the population.
Yeah, it actually it was comprising of family members, and there is more than, I think, above 20 we have included, because the employees are from 19 years and all. So 20 to up to 75, 80 retired employees are also included. Family members are also included, and the population study was almost 4.4 thousand, 4,000 some 100 studies.
That's amazing work, and that shows a lot that India has the capability of doing deep into and getting deep into the nitty-gritties and the analysis that you shared. As cardiovascular diseases also come as part of lifestyle diseases, which includes blood pressure, hypertension, hypotension. So, as you rightly shared, more initiatives are required so that people get more and more aware that, this might be the problem that they may be suffering from, what this is, who to seek for professional medical help, so that they do not go to those, practitioners who are not specializing in this, and, and also to identify other sorts of challenges that come about around this space. So my next question is to Dr. Borkar again, sir, as our topic for discussion is analyzing the current status and challenges. So we saw the status in few different areas of the expertise of our panelists here. What are the biggest challenges that you feel you face as being a medical superintendent with South Goa District Hospital? What are some of the challenges that you feel are big and also needs to be addressed in near future? Also, what do you envision the role of preventive measures and early intervention in reducing the burden? How would this help in addressing the challenges, if it can? Over to you.
Yeah, Dr. Savri, the thing is, as we have said, unawareness of the disease is the biggest challenge. And changing cultural patterns is the second challenge. Those who are aware also are not able to control their eating habits, their lifestyle. That is a big challenge. And therefore, considering these two things, that people, most of them are unaware, and those who are aware also are not ready to change. The only thing that we can do is, do continuous IEC activities, do screening activities. In our hospital, each patient above 30, irrespective of whether he's symptomatic or not, we are mandatorily checking the blood pressure. We are also trying to develop a hypertension inventory so that we have the data for us for further analysis. We also have in our hospital what we call as lifestyle modification counseling. We have a counselor who specifically will advise them on what to eat, what not to eat, and as our Ayurveda says, ahar, vihar, and vishranti. So with this some catchy things, we tell them about what to eat, what not to eat, because we try to stress them with the catchy things like khal tase bhal, what we call it in Marathi. We in Konkani call it tashe tumi khatle, tashe tumi zatle. I mean, these are some catchy things that we tell them. And we tell them that being obesity, the first, the risk factor, what they eat matters a lot. Second is vihar, that is vishranti, exercise. The things that will control blood pressure is their loss of weight, and exercise would do that thing. And we tell them to have a walk at least for 30 minutes. And so also rest. What we envisage by rest is the peaceful life, stressless life. So these are the different catchy slogans that we tell them. We have a counselor right from, say, 9:30 to 4 p.m. and all the new patients are sent to this counselor. And then every time they come for follow-up after, say, 1 month, 2 months, or 3 months, they are again made to go there, and they try to find out whether they are doing the right things for them. So this is a lifestyle modification that we aim at. Secondly, we have school health program wherein we try to stress upon this message of a good, healthy lifestyle to the students. And by using the student power, we are trying to go to their parents and to, the new upcoming hypertensives and diabetics. So we try to teach the students about their eating habits, their lifestyle, their exercise, everything. So these are the two different things, because we cannot go to each house and, see what they are eating. The only way we can approach them is by doing good IEC activity. And in terms of what we do the best in Goa, perhaps one of the pioneer states all over India is we have something called as a STEMI project, that is ST elevation myocardial infarction program, which is even at the peripheral level. And government of Goa is giving free tenecteplase injections to all the patients who have ST elevation MI. We have a tie-up with a company by name Tricog, and they advise us 24/7 whether the ECG is normal, abnormal, and accordingly, we have conducted, trainings for all our medical officers, all our nurses, and they themselves, in the first hour of MI, they can give them tenecteplase free of cost. If taken in private, it's costing something around 20 to 30,000, but in Goa, we give it free of cost. And then, of course, we refer them to our tertiary center like Goa Medical College for further treatment if the need be, or else we treat them in the district hospitals themselves. So I would say we are going in terms of preventive, promotive, and curative aspect, right from the beginning till the end. And for data generation, as I said, we have a hypertension inventory that we are looking at, so that all the patients are registered. If they don't turn up for follow-up, we give them a call after 3 months. We wait for them for 3 months. If they don't turn up, then we give them a call. So this is how we are doing it. The only constraint for us, as everywhere in India maybe, is that the workforce would be little less than what we expect to have this state-of-art treatment and other facilities. But I believe Goa, with this high GDP and our good infrastructure and health infrastructure especially, we should be doing, we are aiming at 25 by 25. That is the goal. By 2025, we are supposed to reduce the death from CVDs by 25%. So we are aiming at that. I hope we achieve that. Yeah. Thank you.
So we hope the same. And just a follow-up question on the same, that is a brilliant initiative and brilliant different initiatives that Goa government is undertaking to reduce, to prevent, to promote, and for curative, interventions for around heart diseases and other lifestyle diseases. We wanted to know if this sort of model is unique to the STMI program that you highlighted. Is it unique to the Goa government, or can this be translated to other states as well, or has this been being followed by other states and Goa has adopted it from somewhere?
No, ma'am. This is our state initiative. This is a state initiative, and now, as I learn, many other states are trying to adopt it, because for this the funding comes from the state, not from the center. So also recently we have started stroke program also, wherein we give same tenecteplase for those people who are coming with the recent stroke paralysis, and their window period is 4.5 hours, wherein for our MI, it is the window period is 1 hour. So that is how we are going about. Recently we have launched the stroke program also.
Thank you so much, sir, for sharing all the brilliant work that you are involved in for improving lives around cardiovascular health. Let me move on to Dr. Smith now. Sir, we would like to know from you, with your experience with the Government Medical College and associated hospitals, considering the evolving landscape of healthcare, that, every year some disease is on the rise and some is on the, back burner. What are the key focus areas that you feel need that need focus and also strategies for prioritizing and enhancing the future of cardiovascular care and its outcomes in your state? What would you feel? What is the focus, and what would be the ways around it?
Yeah. Dr. Asavari, I'll like to share very happily that our government is very well focused on treating and managing cardiovascular diseases. And what Dr. Borkar was proposing for Goa, though we do not call it as a STEMI India like Thomas Alexander from Tamil Nadu used to call it, we have a similar program, and our tenecteplase or a third generation thrombolytic is available at least at the district levels, if not at CSC and PSCs. Though government, some CSCs and PSCs which do send a requirement or do have a requirement, there since 2015, tenecteplase and retiplase are available for to be dispensed free of cost to these patients. In the same the ICMR funded project, it is also coming up, and there are 14 centers or 14 states which have been chosen as a Care India project, where stroke, cardiovascular and other diseases are to be emergency treatments are to be focused, and we are again proudly one of the centers which has been into this considered into this project. So there also the reach would be actually to the patient's home. If the patient gives us a call, then the treatment would, the ambulance, well-equipped ambulance and personnel would reach to the patient's home, and the patient would be treated then and there. The other difference that I find it that in our state, it becomes a mandatory for patients to undergo a pharmaco-invasive therapy. That means if the patient has undergone a tenecteplase or retiplase or any thrombolytic, then the government facilitates a free of cost angiography at our center, and followed by, if required, any other cardiac intervention which is required. And recently, which is probably unique to Chhattisgarh, is again an initiative by the Chief Minister of Chhattisgarh, which is above the Ayushman Yojana or other yojanas by the government, central or state government, that there is a fund allocated 20 lakhs for a below poverty line. Now, it recently, yesterday, it has been raised to 25 lakhs of no question asked expenditure for a below poverty line patient. So below poverty line patients, whenever they land up at a government hospital, they'll be immediately treated rather than waiting for a sanction or any application or anything. For above poverty line, definitely it needs some sanction, but then also it is done. The other things that government is taking, probably the focus, which I appreciate very much, is on prevention of cardiovascular diseases, because we all talk about third generation thrombolytics or angioplasties or angiographies and pharmacoinvasive strategies. The prevention part is, in fact, like there is a gutka ban. Tobacco containing gutkas are banned in Chhattisgarh. There is a plastic ban in Chhattisgarh. So all these things, though it may be taxing, it may not be bringing taxes to the government, but definitely it is bringing lives to its citizen. So these are few things. The focus probably which I feel is now lacking and is required is recreational or playground spaces in the communities. So our children are becoming obese. They are moving away from those traditional play. Again, the government is they're trying to promote the traditional, there is a Chhattisgarh Olympic which are held, which only cater to the Chhattisgarhi population, and they try to have Chhattisgarhis play their traditional games, which involve a lot of activities. So probably, and they do not cost much. They do not cost, a bat and ball and a wicket and a ground like that. So that is one of the good things, that they are made from the local things and which are pretty cheap, and they give good exercise to the children. So these things need to be promoted. And another thing is millets. Millets and is another product which is from these states, probably Dr. Das, in Orissa, from Chhattisgarh, Madhya Pradesh, Rajasthan. Here we had been using millets traditionally for since long, rather than the rice growers in the south or the wheat growers in the north. And millets, now we understand, is again something which is promoted widely, and it is being adopted by the government. So all these things do tell us that the government is focused, and these things are bringing out results, and they have a good promising future also.
Thank you so much, Dr. Smith. Thank you for highlighting all the brilliant initiatives that the government of Chhattisgarh is undertaking. So as you pointed out, that there is still more need to have physical activity as part of the younger population's regime. Some of the different initiatives that the government is getting involved in is building recreational spaces, local Olympics, promoting the children about the importance of exercising and daily walks, etc. Another good way of incorporating mobility and movement amongst the younger population could be with the help of emerging technologies, such as everybody these days has some form of phone or the other. If we were to make an exercising like a game, through a reward point and a basis with the help of any software by the government, and the more you walk or the more steps you cover, the more points you would get, would also help in encouraging specifically the younger population for going out and getting the movement in. So let us now move on to Dr. Das. Sir, with your extensive experience in railways and also into research projects involved, can you please highlight how is emerging technology, as railways is one of the sectors which is equipped with the latest and greatest technologies by the government for related to health? Can you please highlight some of the latest benefits of using technology and telemedicine, or which has played that you have come across in improving access to cardiovascular care for different areas, including the remote areas as well?
Yeah, very nice elaborative discussions going on. I would like to come to your this question a little bit after some time. Let me know. Let me tell you that recently I have come out from railway, and I have been doing some piloting charitable work in the, as Dr. Smith rightly pointed out, about Odisha is an adjacent state of Chhattisgarh. So since I initially I was staying and it's my native place, I had some idea that it's really this adjacent part of Chhattisgarh in Odisha is very, very underdeveloped, and it's a tribal dominating area. Very the light of civilization has not yet fallen over a maximum part of it. So it was my interest to, after coming out from railway, to go and do some work there. And so I consulted district magistrate and district medical officers, and they also told you can also, I can give you some available manpower and machines, but I can't give you extra hands to do. So somehow it's a very small area and very small time unit. I have worked there for last 4.5 to 5 months, and I found the things are different. The problem of fast food and problem of these inactivities is a little bit less. The awareness in the form of, suppose there is an STEMI, there is a heart attack, the patient should not come out from house. I have arranged the primary health centers and CSTs with all oral loading dose medications, heparins, and ECG also have been provided, and the staff have been trained. When the patient comes, you pick up, and we have kept the WhatsApp facilities to our group. So whenever the patient comes, they can take up and then immediately send to me or some other physicians. So we can detect and advise them over phone, and they can see the patient. Problem is the patient do not come out from home. They believe in some other things. If at all they come to hospital, and they will say, you have a heart attack and I'm giving you treatment, and you go to the other nearest hospital or go for angiography and all, they won't come out from that village. So that is, we are now struggling with that. And infrastructure, it's very poor. We are struggling hard, and I'm trying to educate and train those staff and the periphery and the doctors repeatedly. I have met 2-3 groups of the doctors for the WhatsApp, and getting sometime the ECGs also, and patients. Some of the patients coming out and getting their treatment done in adjacent city Raipur, where we have got facilities of primary angioplasty also. Now, coming back to your question, whether the telemetry or any other new technology were helpful in railway setup. Yes, I think you go back to almost 2004-5 in our ACCR railway, we had telemetry started 2004, middle of 2004. We had in Nagpur, we had in Bhilai, and we have in Raipur and in Bilaspur. So 4 units were there, and the peripheral units used to bring some patients for consultation with the specialist sitting over the headquarters in the Bilaspur hospital, and they used to have some regular activities and things. But it's not for exactly an urgent things. It's all on routine discussions and some difficult cases discussions and consultation over telemetry. But somehow there are some technical difficulties, and we could not come out with those things. So finally, it was stopped for some time. Again, is restarted in 2009, went up to 2011-12. By that time, this smartphone culture and WhatsApp came in. So we used this, and particularly we had some incidences of railway drivers, the engine drivers. They are called as A1 category in railway. The A1 means their eye visions, their alertness, their health status checked every year after 45, and so they are to be kept almost alert. These people sometimes started getting chest pain, and sometimes they have to go off the duties, and so we had a lot of difficulties in our sections. So what I did, I called those peripheral doctors who are covering all those stations like this, and gave them some tips and displaying some posters in Hindi. If this happens to you, you should do this, you should not do that. And we have provided some the oral medications which are given primarily to the suspected STEMI or acute coronary syndrome patients. So these were provided, and the doctors were told to be alert on whenever this patient comes. It happened sometimes that patient went on taking boron injections and antacid gels, and finally after 13, 14 hours, one fellow detected, and then patient was shifted 24 hours after to my hospital for further angiography and angioplasty. So with all these things, we decided to go for this. Immediately use this WhatsApp and take the ECG. The ECG machines were kept nearby. Somehow the communications were like that. The TTs used to tell that the next patient is coming by the train, so you get him to the nearest doctor, whether it's a private doctor or wayside station, whatever it may be. And then the things come to us. We tell them over phone, you give this thing and send the patient. So somehow the technology of mobile telephonic communications through WhatsApp helped us a lot for last 3 to 4 years. Before COVID, we started this project, and I think now it's again geared up, and a lot of lives could have been saved by this technology, definitely.
Thank you so much, Dr. Das. With that, we come down to the end of this very super interesting session on Get Smart with Your Heart series. Before parting, let me have a last takeaway message from all our panelists over here, starting with Dr. Borkar. Sir, your key takeaway message for the World Heart Day initiative.
My key message, the takeaway message would be very simple. Again, a crispy message. The message is each individual should give 24 minutes a day for the heart. And then heart will work for you 24 hours. So for 24 minutes, if you do something for the heart, that is exercise, then heart is going to serve you for 24 hours. Heart is one organ which is working even before we are born and till the death. So if the heart is doing so much for us, every day 24 minutes is not a big deal. And secondly, I would want that each individual would check his heart status in terms of maybe blood or ECG or whatever, at least 6 months biannually. Then we know how the heart is working for us, what we should do for the heart. So we should be aware of something that is working for us 24/7, give it 24 minutes, and every 6 months, just check whether everything is okay. So that should serve the purpose. Thank you.
Thank you so much, Dr. Borkar. Dr. Srivastav, sir, your key takeaway message for the audience. Sir, you're on mute.
Yeah, I concur with what Dr. Borkar is advising, what he's prescribing, but there is a little bit difference that seeing to the patients that 1/3 of our patients are under 35 or 40 years of age. I feel that the screening should start, the target screening should start at close to age of 18 and 20, not at age of 35 or 40. That it's too late for Indians. It may be good for the Westerners, but for us Indians, the best preventive time that we would have would be between 20 years and 30 years of age, the third decade. And therefore, we need to screen our patients. Rather, the patient needs to screen themselves after age of 20, as soon as one enters or one graduates out of school. And that's the only message I would like to share here.
Thank you so much, sir. Dr. Das, sir, your key takeaway message for the audience.
Yeah, for this World Heart Day on 29th of September, I have my messages in two groups. One is for my doctor colleagues, and the other will be for the people around. Doctor colleagues, I know we all are busy in our day-to-day work assigned to us in a curative setups, but I have experienced this 35 years job in railways and few months in state government. I have been doing some surveillance and giving my services. I found these people need experts some time to make their have some time to be with them and make a team of your group, so that the primary prevention, I'm insisting on that. It should be a primary prevention rather than getting them for angiographies and taking up for angioplasties or interventions, because it is well said that these all 9 factors which have been calibrated on us, all are reversible and all are preventable and all are in our hand. So if you can give basic primordial education to that staff from the high school level, from the students are coming out from the school life and up to the 70s, 80s, this is a geriatric group, in between everything, all ladies particularly, how to prepare the food and which oil to be used, all these things in conglomerated in group should go. At least one senior physician or cardiologist should go in some intermittent meetings and address the people. With that interest, they will be accepting it. Secondly, to my people around in our country, we are early, as Dr. Smith has rightly pointed out, very rightly pointed out, that we are treating heart attacks, STEMI. Recently, we have treated a 19-year boy of Korba who had an acute MI, STEMI, because of tobacco involvement. And unfortunately, that hospital was having connected and he was given, and we found that angiography was almost very canalized artery. So these are the examples that up to that level you have to focus, and my people around should get the message that everything in our hand. Yes, if you determine agar aap ठान लेंगे तो आप कर सकते हैं. That's all.
Thank you so much. With that, we come down to end of this super insightful session on Get Smart with Your Heart, an initiative of Integrated Health and Wellbeing Council powered by Boehringer Ingelheim. I would like to thank all our speakers for joining us, for sharing a wealth of knowledge and information with us. Thank you so much. Thank you, Dr. Rajendra Borkar, Professor Dr. Smit Srivastav, Dr. C.K. Das. Thank you so much. We would like to thank our partner, Boehringer Ingelheim, for partnering up with this brilliant initiative of Get Smart with Your Heart. Thank you. Lastly, we would also like to thank all our viewers for staying with us till the very end. I hope the session was as insightful and informative it was for you as it was for us. Thank you so much. With that, we sign off now. Stay happy.
Thank you so much.
Thank you.
Thank you.
Thank you so much.